On examination, the 1-2 is extremely shaky and all around gingival swelling around the 1-2 and 1-3 area with no buccal keratinized tissue at the 1-2. You shoot a cone beam CT to find severe periimplantitis at the 1-3 implant, around 6 to 8 millimeters of bone loss around 1-2 and 1-3, which brings us to the crux of today's topic, which is salvaging, rebuilding, preserving the architecture of bone and soft tissue for anterior implant aesthetics. There are many, many ways to rebuild or at least try to re-architecture the missing components. The first and foremost is guided bone regeneration using barrier control, where a membrane of some sort maintains space with or without recombinant human bone morphogenic protein. Second, we have on-a bone graft where we take a block of bone from the chin, ramus, hip, a motivational speaker coming along looking like this, basically afraid of smiling in public and terrified of showing her gum line. On examination, 1-2 exception is shaky with all-around gingival swelling and no buccal keratinized tissue. We follow up by shooting a cone beam CT to find severe periimplantitis in 1-3 with around 6 to 8 millimeters of bone loss around 1-2, 1-3. Which brings us to the crux of today's topic, which is salvaging, rebuilding, preserving architecture of the missing bone and soft tissue. Many ways to rebuild what's missing. Guided bone regeneration with BMP2, on a bone graft with harvesting from chin, ramus, hip, or even allograft material. We have interpositional graft, which works really well in vertical augmentation, where a segment of the crestal bone is actually separated from the base using either a saw or a piezo and lifted up superiorly, and particulate or block bone graft is actually inserted in between with coverage of mucosa afterwards. We move on to edentulous-rich expansion, which only applies to horizontal augmentation, where the old school way is actually to use a scalpel and mallet, where you go to the knife edge of the ridge and hammer it down and gradually expand the space with implant or spreaders. Nowadays, we use piezoelectric, and the spreaded space is actually filled with particulate graft, and sometimes simultaneously with implant. Distraction osteogenesis is a really good way to increase a lot of height when there's really basal bone left. However, it doesn't really address horizontal because you're actually left with whatever is available at the basal level. And we move on to more technique sensitive stuff and more advanced stuff like vascularized bone graft. But the main crux of it is all techniques actually allows for excellent implant survival, and it really depends on what you want to do and what you're comfortable with. Mish et al. Actually created a decision tree and tried to split it into 3 broad categories, spreading it to low, where it's less than 5 millimeters of vertical bone augmentation, medium, and high. And he basically based it on extra-osseous bone height that we hope to create. And if you look at it, guided bone regeneration, block graft, titanium mesh graft, interpositional graft, orthodontic extrusion, all the way to distraction osteogenesis. It provides a really great starting guideline and runs the gamut of what material we have in terms of collagen membrane, titanium reinforced dense PTFE. It also touch on autograft and bone substitute. And based on this review, and the lowest complication rate is actually associated with guided bone regeneration of roughly 25% based on his study. When we go to horizontal augmentation, the same thing. Wang et al. Also created a decision tree based on bone gain in the 3 broad spectrum group with most of the same techniques with the exception of ridge split and bone expander being for horizontal bone augmentation and subperiosteal tunneling for anything that's less than 3 millimeter. And it's the same thing. Guided bone regeneration has the lowest complication rates with roughly 18%. So let's dive to a few of these GBR techniques that's promising a lot of excellent bone gain. Sausage technique is originally described by Dr. Istvan Urban using PTFE membrane. His approach is advancing the lingual flap along the mylohyoid ridge while preserving its attachment to the mandible. He also utilizes or advocates using pins to fix the membrane and sequencing it. By sequencing it 1, 2, 3, 4, followed by bone placement of a mixture of 50 to 50 xenogenic and autologous bone, followed by pins 5 to 7, and if necessary, pin 8. Full closure with double layer and continuous or whatever means you want, and implant placement roughly 6 to 8 months later for proper healing. The main thing about this technique is you have to remove the membrane because PTFE is not resorbable. And a lot of people, or I would want to say this is relatively technique sensitive, like all techniques, that's good. We move on to periosteal pocket flap or mucosal detachment, which is popularized by Dr. Marius Steitman. Basically, it involves a incision at the crestal level down to the bone using some form of instrument to apply mucosal detachment or split thickness flap to allow the periosteum to still adhere to the bone, followed by separating the periosteum from the underlying bone. Creation of this periosteal flap, followed by packing of the particulate graft into the pocket with or without resorbable membrane, and then followed by suture fixation through the periosteum to the lingual flap or the crestal edge. Primary closure. The great thing about this is because of the high autogenous bone graft ratio, you can actually place implants roughly 4 months later. It is equally technique sensitive. However, it requires lesser specialized instruments. If you prescribe or you subscribe to Dr. Steitman's technique and you want to use his proprietary Steitman tissue splitter, you can. Personally, I use both of them, where a tissue splitter or a peritone works really well. The peritone we use to remove tooth prior to immediate implant placement. Cortical tenting graft or quarry technique is popularized by Dr. Floyd Quarry, where a thin cortical ramus bone is harvested and then split thinly, and the cancellous edge or side is actually removed to bulk up the mixture of cancellous, autogenous, and xenographic grafting. These cortical plates are screw fixated to maintain a 3D-dimensional shape depending on where and whether it's horizontal or vertical augmentation. And the gap that's created by this, the gap that's created in between the graft site and the cortical bone is grafted with mainly autograft. And you can either put or not resorbable membrane and primary closure. Implant is placed roughly 4 months later. It is highly technique sensitive and it requires a lot more instruments like P8 store, Restore, and titanium screws. The autogenous graft that is needed for all three technique, there are many ways to skin a cat. You can take it from the ramus, you can take it from the chin, you can take it from the iliac crest if you want to, or even the proximal tibia. Personally, I love using the implant drills or flute or a bone collector like the one that we see on the left. Each pass at roughly 70 Newton centimeter at 35 RPM allow us to collect a lot of bone at very minimal time. Or if you feel like you need to work out with fingers and stuff, you can definitely use it manually using the bone scraper that is single use, or a reusable bone scraper like this, or the micros of from Meta. Um, Personally, I love harvesting it from the regional or adjacent site of where we want to, I want to augment, and it will typically for the anterior region, I will harvest it from the palatal aspect. As for bone biomaterial, we have the normal. We have processed bovine granules, we have allograft in the form of particular or putty or block, we have alloplastic hydroxyapatite. We also have alloplastic material like beta tricalcium phosphate. They all work pretty much similarly as fillers and as structure or shape to give you structure and shape for your final bone graft, except for RHBNP, which has excellent osteoinduction to create osteogenesis. However, what you end up with is a patient that's not that happy because of the crazy edema that's associated with the BNP. Barrier control is the same. You have a plethora of options available. You have a collagen, both cross-link and non-cross-link. You have the PTFE, which is non-resorbable, and PTFE is actually the same ingredient as your non-stick pan that you use at home. So it's really good. It's good for growth of mucosa. It's good for everything, but you have to take it out afterwards. You have a titanium mesh. You have your BioExclude, which is amnion chorion membrane, and you have an alloderm. They all works the same with different handling material and characteristic, with the exception of BioExclude, which is an amnion chorion, which has reported antibacterial properties. If we want to compare cross-link and non-cross-link collagen membrane, I personally love using the cross-link collagen membrane because it's more durable, especially for large augmentation. The degradation time is roughly 4 to 6 months if it's underneath the mucosa. If you have unfortunate wound dehiscence and is actually exposed, what happens is it will at least last 3 to 5 weeks prior to mucosalization. And it is reported to have biocompatible issue and higher immune reaction. But personally, I don't really observe it in my patients. And the good thing about cross-link collagen membrane is it sometimes see ossification happening on the membrane itself. If I actually see the patient roughly 6 to 8 months later, and I actually still see the membrane there, but it's hard, almost like it's bone. Barrier stabilization is actually pretty critical if we're going to do bigger and bigger bone graft. You have your pins and tacks from Meisinger or any brand that you can come up with, or it's great to use, especially for the maxilla, but it's exceptionally tedious for the mandible because it's highly cortical in nature. You have to pre-drill it and tap it in. So as for the mandible, I don't like using it. I prefer suture stabilization through periosteal stabilization of the buccal and lingual with vertical and horizontal mattress. When it's done, it almost looks like a rib roast or a porchetta if you like Italian food. Just pretend you're a chef for the day. And after we're done with that, let's move on to our first case. Jerry here, that's not her real name. It's a straightforward case. She's sick and tired of a bridge and wants an implant. And take an OPG and a cone beam CT, you can see that she has relatively good bone height, but she has the concave buccal defect. We got to replace that. So we will need horizontal augmentation of roughly 4 to 5 millimeters and a screw retain count to be fabricated. The question is, how do we do it? How would you approach this? Will we be using a GBR with immediate implant? Will you be using a block graft with immediate implant or sausage technique with mucosal detachment and late implant or quarry technique with late implant? There's no real right or wrong answer because it's just personal preference. Seems like we have a tie, GBR and sausage technique and immediate implant. Okay, all right. Well, personally, I didn't do immediate implant because I want screw retained crown and the available bone doesn't really allow for it. I went ahead with the sausage technique with the 50-50 autogenous and xenograft along with the resorbable membrane with both the buccal and plato flap, harvest bone chips from the plato and place implant 1, 2, 3, 4 to create a pouch using the membrane. And I packed in the bone chip mixture, followed by finally pin number 5. 4 months later, we take a cone beam CT, and you can see that there is, I think, adequate bone for an implant. It looks a bit odd, but luckily it doesn't really show in the patient's profile because the thick tissue in the lip and the muscles. However, if you look at it intraorally, you can see the buccal contour can be a little bit better. Like incision as usual for implant, extending palatally with a split thickness extension. And what happens is by doing this, you can easily beef up the buccal contour by rotating it inwards buccally and then place an implant in primary closure. 12 weeks osseointegration, you can see pretty good reach. And off she goes to get her new crown. And this is how she looks last week on review, luckily, because she's actually a nurse of mine. Decent, but I would say she would probably benefit from a longer crown and more gingival molding with the orthodontist. If we move on to the next case, Carrie wants a new smile. She went ahead and did veneer of all her front upper teeth except for a 1-2. Why? Because the 1-2 is shaky. She has relatively interesting gum line at the 1-2 with funny discoloration, and buccally there's lack of keratinized tissue or mucosa. Take a PA and OBG, you see super short root. That's why it's shaky. And the 2mm radial lucency. If you shoot a cone beam CT, and we can see the effect of repeated RCT episectomy, where the bone is actually almost gone with a through and through bone defect to the palatal with absolutely no buccal bone. So how would we approach this? Do we take out the 1-2 GBR and immediate implant? Block graft and immediate implant? Or we go through the same thing, sausage technique, mucosal detachment, and late implant, or quarry technique and late implant? Once again, there's no right or wrong answer. It's just personal preference and what we're comfortable with. Good. I see that there's some adventurous people with like immediately taking out a 1-2 GBR and immediate implant. All right. I didn't. I don't think I can do it well if I place immediate implant. So what I went ahead is I placed a circular incision and triangular flap with a wide flap to more or less guarantee vascularity and coverage with the bone graft with one releasing incision. The downside to this is there's still some form of papillary elevation, so we do expect a little bit of light bone resorption at the papillary region. After raising the flap, what we see is this. This is the bone defect. Minimal platal bone left, through and through hole occupied by soft tissue, I did a rib roast or sausage technique GBR with cross-linked membrane and parasteel suture stabilization. And where do I harvest the bone? From the palatal using a bone collector. So each pass of the bone collector actually gives me this amount of bone, and each pass will take roughly a minute. I'll mix it with my xenograph or whatever bone substitute I want at the ratio of at least 50, but typically 60 to 70 to 30% bone substitute and blood. What do I get in return? We get a pseudo quasi sticky bone. It's not a true sticky bone, but it's sticking together because the blood is clotting and it's easy to handle. Okay. 4 months later, this is what we get. Pretty good result. And if you look at it, we actually over-engineer the bone defect both vertically and horizontally, and definitely enough bone for an implant. Place an implant, and during implant placement, do the same thing, palatally extend split thickness flap and roll it to the buccal. And at 12 week, the implant is ready. We get good, rich contour, buccal keratinized mucosa. We even managed to migrate the stain of discolored mucosa cephalically. Pretty good. And if we compare before and after, pretty decent. I'm pretty happy with the outcome. We move on to the next case. Marie here, do you remember this lady, our motivational speaker? Well, her 1-2 has mobility 3, all around juvenile swelling, just to recap. No buccal keratinized tissue on the 1-2 and severe periimplantitis on around 6 to 8 millimeters of bone loss all around. More background history. She has and currently has chronic periodontitis. Sent her to the periodontist for some maintenance to increase or stabilize her gingival tissue. She previously had an onlay block graft and a 1-3 implant, even though the 1-2 is actually shaky. So this is what we have. What would you do? Explant the 1-3, remove the 1-2 with autologous block graft, remove the 1-2 only, find some way of disinfecting the 1-through with xenograft, autoxenograft, or autologous graft. So the poll result, most people will actually keep the 1-2 and 1-3, keep the 1-3 and disinfect it. Well, that's exactly what I did. Wide incision again, avoiding the papilla. This time around 2 vertical incision because of the massive loss of mucosa and soft tissue, I anticipate a lot of extension and rolling in palatally. And this is the horror that we see after you raise the flap. Extensive granular tissue around the 1-3 implant. The 1-2 is shaky with almost no bony root coverage and some form of tooth color filling on the root just to mask and increase aesthetic. Basically, I scrape and scrape and scrape and use a titanium brush to remove any debris on the implant. Decontaminate it with chemical antimicrobial. I prefer using phosphoric acid, like the etchant from composite, and povidone iodine afterwards, and a lot of rinsing. And then harvest the bone from the palate to mix with our bone mix. First, laminate the peri-implant with pure autogenous bone chip and over contour the 1-2 and 1-3 with the 50-50 autograft and xenograft, extending both buccal and palatally. You can never have too much. Slap on multiple layer of collagen membrane and suture periosteal fixation. If you look at it, I try to like almost imagine this is the implant for the 1-3 and this is the 1-through. but I think I made a mistake by putting the suture too distally, and we will see the after effect. This is close up, and 4 months later, we get to here. Cone beam CT shows adequate bone height for the 1-2 implant, but we definitely I would definitely prefer more bone at the crestal region. Good bone coverage of the 1-3 implant. And if you compare it side by side, this is what we have. Good bone coverage at the 1-3 implant, just short of covering the whole implant. And if you look at it from the bottom, we can see that the 1-2 side is actually has a lot more space for improvement. And if you look at it, I think this is the mistake I made. I placed the suture fixation too distally, which compresses the bone graft. And then I'm ending up with a bit of a lost bony contour. This is what we're at afterwards. Are we in a better place? Definitely. Do we have more room for improvement? Absolutely. She's smiling again, so I guess that's worth a lot. And she's happy, so her low gum line or low smile line actually helps a lot too. So personally, I think preservation is gold. Rebuilding is good, but preserving is infinitely better. Immediate implant is always better if possible. And if you can, you always graft the gap. And do remember Dr. Bruce's research and stuff, and not forget the bundle bone resorption. That's going to happen no matter what. And place an incision at the labral frenum, tunnel graft it to the buccal, and then basically graft the buccal on the same day of implant placement, immediate implant placement. If you do it well, and if you're lucky, and if I'm lucky this time around, I end up with a pretty good result and patient's happy. We managed to preserve all the architecture and we achieve what we want. So in summary, I think, in summary or take-home message, guided bone regeneration does have the lowest complication rate, both for vertical and horizontal bone augmentation at roughly 25 to 18%. And as for a graft mixture, it actually plays a critical role because if you have a lower autograft at 30%, you might have to place the implant roughly 6 to 8 months later. If you bump up your autograft ratio to 50 or 70%, most likely you can place your implant roughly 3 to 4 months later. All right, that's all I have for today.
Okay. Thank you, Dr. Liu, for for sharing your cases and giving us a very good summary and overview, as well as the details of the various bone grafting techniques in the anterior region. Let's see if any of our participants have any questions. Feel free to ask or submit it in the chat room, and we will address them. So in the meantime, I have a question, Dr. Liu. So you seem to be getting most of your grafts, bone graft autogenous from palatal so far for the cases that you have shown. And I guess it makes sense because you're working in the same surgical area. So it saves the patient a second wound indeed. Do you encounter any difficulties with getting bone graft in the palatal area? Do you have to raise the palatal flap a little bit further wider, or any like bleeding or hematoma or post-op precaution that you take for these area of grafting?
Well, extending the flap laterally provides a definite reservoir of bone to harvest. As a result, you definitely get some hematoma there. I'll routinely place collar plug or some form of collagen in the palate, and thus far, most, if not all patients have not really shown any problems or any complaints or increase in pain. As for how much bone I can get, it really depends on anatomy. Sometimes it's roughly 2 millimeter thick, and then the maxilla palatal region, and I have to go to the mid segment where there's a alveolar maxillary crest to get more bone. I actually would not hesitate to go all the way through, even though the bone collector might actually touch the nasal mucosa because I'm not going to damage it. And what happens is afterwards, the body's just going to regenerate. And empirically, I do see that because I sometimes see the same patient for grafting on the opposite side, the opposite quadrant, and I have to go through the palate again. And I do see normal pristine bone afterwards. So not much increased complication as I can tell. Yeah.
Okay. So I guess yeah, putting like a cold plug or something to absorb the to get a stable clot is quite useful and effective to preventing a hematoma. What about grafting the incisive canal? You know, in the anterior region, sometimes we encounter bone where the incisive canal may be very prominent. You haven't shown any cases where do you find them like when you're in that area? Do you usually graft them or just leave them behind? Or what kind of graft material would you use if you have to?
Well, occasionally I do encounter the incisive canal where it's inadequate space or bone thickness for an implant to go in without touching it. Then I might have to graft it. And if I have to graft it, I purely use autogenous because why not? It's so easy to just harvest some from the palate. Um, but then we sacrifice sensation.
Yeah.
Yeah.
Yeah. Among the grafting technique that you have covered, I just wanted to ask about like buccal onlay grafting. We did not cover that a lot today. Do you do it any differently? Do you add for the GBR for the buccal onlay? Do you usually get the graft from the ramus or the chin, or is the mixture component kind of like what's here in your summary too, that you would still graft a lot of xenograft on top or sandwich it, or we add like additional, you know, PRF membrane that's quite popular too. Do you combine all of these, or
Well,
what's your
I do less and less of block graft, but if I have to do, it's because I want to do simultaneous or immediate implant placement. So if I want to do immediate implant placement, I'll actually take the block bone from the chin, where I can take a ring and I can prepare the implant in the ring and sandwich it in the graft site. Then on top of that, I'll put xenograft, and obviously there's membrane around. I'll put a membrane too, because why not? Yeah. But in terms of taking block graft from the ramus, I don't really find much use for it because GBI with suturing or bone tech actually works so well, and just doesn't make sense to go there and increase another site and increase pain and suffering and prolonging surgical time.
do you add PRF in any of your GBR techniques?
Uh, I personally try to keep things as simple as possible. I don't like taking PRF, as you can, because I just don't like doing that much stuff. If because basically there's not much problems in healing even without. So I personally don't find a real use for it in my hands. Um, if there is actually, in terms of for other supplementary surgical procedure like connective tissue graft, sometimes I'll do it, but typically I'll use, if I need contouring after bone graft, I'll use stuff like Ossix Volume Max or BioGuide Compress and stuff like that, just to bulk up the region, because we don't really need that much more than an implant. And if adequate bone is present, and we just want to contour it, we can use whatever means we have without, yeah.
Yeah, so great stuff, and thank you again for speaking on this topic and sharing your cases. So far, we're not getting any questions from our participants, but we've had quite a few participants today. So thank you all for your participation. Before we end, we just want to do like a last poll for our event feedback. So if you can just take a few minutes, a few seconds to give us a feedback, so we can improve on our subsequent study clubs. We enjoyed everyone's participation tonight, and thank you, Dr. Liu. I hope everyone have a good night, and I hope everyone can also review, reflect, and keep themselves thinking on all these bone grafting techniques, because we kind of have to keep ourselves always up for the new things that's going around. But I'm sure if you have any questions later, if it's not now, this is the email address that you can feel free to address and ask Dr. Liu personally if you want to. And so that's it. Thank you again for all your feedbacks. We're seeing more of that.
Thank you so much, May, for having me. And thank you, AOCMF.
All right. Have a good night,
All
everyone.
right. All right. Thank you. Ciao.